Good morning, everyone. Uh, Again, my name is Arnaldo Valedon. I'm an anesthesiologist in the Washington, D.C. Area. I'm also a board member for the ASC Association in the United States and representing the association to the General Assembly for IAAS. First and foremost, I'd like to thank the organizing committee for allowing me to be here with you in Budapest this morning. What I would like to do briefly this morning, and I apologize, we've had some issues with the Mac to PC conversion, but we should be okay here. I would like to briefly go over the expansion and development of ambulatory surgery in the United States. We've been at it for a long time. It's been a very interesting process. And before we go any further, I'd like to very briefly go over some definitions so everybody's on the same page as to what we're talking about. Very important when we're talking about outcomes and definitely expansion into multiple sites of service. So outpatient day surgery is any surgical admission less than 23 hours and 59 minutes. I can tell you that admissions in the U.S. are definitely under 6 hours, the vast majority, and the great majority of that under 3 hours, and that is from patient in to patient out and discharged. Ambulatory surgery centers, ASCs, they're freestanding facilities, not typically physically linked to a hospital, and of course, offering day surgery and procedures for patients. Outpatient hospital departments, HOPDs, these are surgical pavilions, typically physically attached to a hospital, also offering day surgery and procedures to patients. And last but not least, office-based surgical facilities. This is what we typically know as an office, a physician office, and they typically have 1 or 2 procedure rooms where day surgery can occur as well. Both as physicians as well as the public, we've grown very accustomed to these type of facilities. And again, what we've seen here is a very typical facility for the U.S. A reception area, which is very common. It is actually quite common to have a flexible preoperative and recovery area. The reason for that is so you can flex up or down depending on your preoperative assessment needs as well as recovery needs. Very, very common. In terms of the OR, again, we have just about anything and everything we could possibly need in these centers for safe surgery as well as efficient surgery. Now, day surgery, as has been mentioned before, started in the U.S. really in the mid-'60s when several hospital-based facilities opened in Washington, D.C., as well as California. The first ASC, and I'm going to concentrate mostly on freestanding ASCs for the talk, started in 1970. That's when it was formed. And that was quickly followed by a rapid growth in the mid to late 70s. In the early 80s, our primary government payer, Medicare, approved 200 procedures to be done, and that's for payment, to be done in freestanding facilities. And over a span of 15 years, that expanded to about 2,000 procedures. By 1998, we had 1,000 ASCs, and by 2011, we have 5,300 ASCs. We know this number to actually be higher now in 2013, with payment approvals from Medicare for over 3,500 procedures. So the trend in surgical volume that we have seen, again, has been very interesting, with inpatient surgeries starting to surpass inpatient surgeries in the early to mid-'90s. And by 2006, we actually know this ratio to be about 44 to 56% inpatient to outpatient. We also know that this ratio is actually higher now, but we're going to have more definite numbers in 2016. The government will conduct a survey every 10 years, and we're going to have better numbers and more definite numbers at that point. Of course, when you see any type of increase in procedures, you need to wonder whether or not the increase is due to population-based drivers increasing utilization. And if that is the case, which it is the case in the United States, then which side of service are they going to be driven to? In our case, as I briefly mentioned before on the definitions, there could be 3 different sides of service. It could be a hospital outpatient department, physician office, or ASC. Technology certainly has helped, but it has not been the only factor. It's been a very important factor in driving inpatient to outpatient care, but certainly not the only factor, but a very important one. What we have seen over time, over here, has been a five-fold increase for freestanding facility outpatient surgeries, and also a five-fold increase in office-based facilities over the decades. Along with that, roughly, we have seen a five-fold decrease in inpatient surgeries as well. So some of our healthcare analysts have actually wondered if this increase will continue to be exponential. And it's been very interesting. Starting in 2011, what we started to see was that even though we continued to see an increase in procedures, the number of freestanding ASCs started to plateau. And that was back in 2011. Now in 2013, we know that this graph is actually flatter. And not only the number of ASCs has decreased, but also the rate of growth at which ASCs are being formed has also decreased. 8.7%, 3.6% in 2008, happens to be about 1.5% to 2% now in 2013. Very interesting. Again, we beginning to wonder if we're reaching a mature market in the U.S. We know that the average, the lifespan of an ASC, number of years that an ASC lasts in the U.S. is on average about 12 years. Many more last more than that, many more less than that, but on average about 12 years. Multiple factors affecting this. There's a finite number of surgeons, of course, that can access the system. But again, what I'm trying to say is that multiple factors, it's not a surprise that we're seeing a plateau at this point in time. Now, let's take a look at case volume by specialty. This data comes from Medicare. So the data is going to be slightly skewed because Medicare is mostly an older population insurance. But the best data that we have, gastroenterology, ophthalmology, and pain management tend to be the biggest specialties that we have. Something that you will not see in here is aesthetics, and that will remain outside this specialty by volume. The reason for that is because these data come from Medicare, and plastic procedures are not covered under Medicare. There are plenty of multi-specialty ASCs that are still in existence in the U.S. They're just not captured under the Medicare data. With respect to ASC ownership, it is legal in the U.S. For physicians, surgeons, as well as other physicians to invest in ambulatory surgery centers. Of course, along with that come a whole array of regulations and laws, but it is legal. So the vast majority of freestanding ASCs that we see are physician-owned, with a smaller percentage that are both hospital and physician-owned. Certainly, it has been yet another factor driving inpatient care to outpatient care. So where are we today? As I mentioned before, there are over 3,500 procedures to be done. Today, we estimate about 40 million visits to freestanding and hospital-based surgical facilities, up from 35 million in 2006, up from 15 million in 1996. In terms of office-based, we're talking about an estimate of about 12 million, up from 10 million procedures in 2008. So what are we doing? Just about any kind of specialty, A to Z procedures. Cystoscopies, lithotripsy, endoscopies, liposuction, breast augmentation. I happen to do a lot of orthopedics, shoulders, knee arthroscopies, anterior cervical decompressions, something that 17 years ago wasn't being done, is actually being done routinely now in outpatient centers. And I can tell you on average, as an example, a recovery time is not unusual to have 90 minutes from the end of surgery to the patient out, maybe 2 hours for anterior cervical decompressions. Lumbar discectomies, bariatrics, all being done. Ophthalmology, of course, cataract, trabeculectomies, ptosis repairs. So A to Z, many procedures that are being done routinely. Now, why has that happened? First and foremost, patients are doing well. We've been able to maintain clinical excellence from one setting to another. Also, that has been very important. We've been able to safely and successfully transfer some of the postoperative observation, as well as some minor tasks, to family members and the patient. This is something that culturally has gone well and is actually expected in the US. Having grown up in Latin America, I can also tell you that the rate of acceptance is not as high yet, so it's very country dependent. In the US, it has worked extremely well. As I mentioned before, technology has certainly helped a lot. Minimally invasive techniques that were only available in the hospital environment are now available both in freestanding facilities as well as office-based facilities, and certainly there has been some financial and regulatory incentives and pressures for that to happen. We have plenty of data now on the clinical side now showing that unexpected complications in freestanding ASCs are equal or less than hospital environments. And that has been a major driver. This is at the heart of really what we do, is good clinical outcomes. This data comes from the ASC Association in the US, and we have the largest volume of data available through the Outcomes Project that is being sponsored by the ASC Association. Mean complications are about 3.2 per 1,000 patient encounters. And again, that's very similar to hospital-based facilities. In terms of patient death, has a mean of 0 with a maximum of 1.8 per 1,000 patient encounters. And when we're talking about mortality, again, comparing hospital to day surgery, outpatients, hospital care, depending on who you quote, 1 to 2 per 10,000 procedures, day surgery, outpatients, between 0 to 0.5 per 1,000 procedures. We gotta be careful here. These data came from 2 different studies, so they cannot be compared apples to apples, but the point here is that the mortality rate is actually quite low in both settings. As I mentioned before, financial pressures have certainly contributed to the switch from inpatient to outpatient. Also, data from the ASC Association shows us that it is indeed less expensive to have procedures done in a freestanding facility as opposed to a hospital-based environment. A whole array of reasons why that is, but that is the case at this point in time, so that has also contributed. And at the heart of the organization of day surgery in the US are government regulations. At this point in time, the government, in order for facilities to get paid by the government, they need to go through an accreditation, a certification process, I should say, from the government. There are 13 different areas that need to be addressed by the centers and be in compliance with. Compliance with state licensure, government body and management, surgical services, quality assessment, medical records, physical environment, medical staff, infection control, you name it. 13 different areas, hundreds of regulations. These facilities are heavily regulated in the US. What this has allowed, basically, is for almost an ASC-specific DNA to be created for ASCs in the US. Of course, these are government-certified facilities. There are some that are not, but you can recognize one when you see one. Now, above and beyond all regulations for ASCs, what many of us believe is that what really makes an ASC work effectively and tick in unison is communication. It's a team approach to what we do, and it really starts with the surgeon. We all believe, again, patient selection is at the heart of what we do. Again, starts with the surgeon in the surgical office, followed by the nursing staff, making a call to the patient ahead of time to, number one, identify any clinical flags, but number two, also to set the tone for what is to be expected preoperatively and postoperatively. Of course, the anesthetist, the anesthesiologist, a very important part of the team, making sure that the whole perioperative process is flowing. Something that we do not want on the day of surgery is surprises. The cancellation rate overall that we see is less than really 1%. In many cases, less than 0.5% for the majority of ASCs in the US. And the reason for that is effective communication. If you don't have surprises, you don't have delays, you don't have cancellations, everybody's very happy. So this system works very, very well. Of course, it takes many years to do that. So in terms of the future, we certainly expect further migration of procedures that are currently being done in hospital settings to move into freestanding and office-based setting. Every year, we continue to see that line moving a little further and a little further. There will be a limit. We're just not sure what the limit is going to be quite yet. Increased patient complexity, for sure, will be happening. We're seeing that as we speak. We've had several sessions, some clinical sessions here, talking about some of the challenges that we have, sleep apnea, among many others. And we certainly expect to see more regulations, no question about it. The rate of growth for regulations for freestanding facilities, hospital-based facilities, and office-based surgery has grown at a different rate. And the office-based environment seems to be lagging a little more. They will catch up. 30 out of 50 states now having regulations for office-based facilities. So more regulations, more financial pressure for sure, and a lot of the financial payments will be tied to evidence-based and outcomes data. We've also have some sessions here talking about quality reporting, something that is the latest trend in the US and is here to stay. Right now we have a quality, a pay-for-reporting rather, system. Pay-for-performance will be coming very, very shortly. And that is what I have. Thank you very much.
Thank you, Arnie. There's a change in the sequence of speakers. I request Wendy Adams, representing